now, given that we have reduced the age group of the talk of the topic, we're also going to reduce the age group of the speakers, because we're going to conclude with 3 short poster presentation. And please pay attention, because you need to vote. And if you don't vote, tomorrow you won't eat. I will count who has voted, because I get your name when you send the email. And we're going to have Marco, Eleonora, and Fatima, who represent Milano, Palermo, and Canada. Fatima, what about in Canada are you from? Toronto. Say again? Toronto. Toronto, okay. So Marco, usually it's ladies first, but in this case it's gentlemen first. And I think your poster is up. Yes. So the rule is you have 5 minutes, and so we will, I was going to say judge, is not very politically correct. We will rate your performance on keeping time, clarity, and of course the content and the presentation of the poster. So be all ready to send your email to Giada and to Brian. And you know, the order will be Marco is number 1, Eleonora is number 2, and Fatima is number 3. So you can give a score 0 to 10 to each of them, sending it to Brian and Giada, please. The first score goes, am I able to have my poster on the slide? Gianpaolo, what's happening to the poster? Oh, there we go, great.
What?
How do you vote? No, you do it online. Yes, you send any speaker, send an email to me.
Hello, I'm Marco Paolini. I'm a PhD student from San Raffaele University in Milan. And my poster is on neutrophil to lymphocyte ratio and antidepressant treatment response, the effect of sex and of hippocampal volume. In recent years, much focus has been put on the role of immune inflammatory mechanisms in affective major depression development and also in affecting treatment response. Among inflammatory markers, neutrophil to lymphocyte ratio can be easily obtained from a routine blood count. It has been originally developed in oncology as a prognostic marker, but it has since been investigated in several fields of medicine, including in psychiatry, where it has been associated, where higher levels have been found in patients with major depression and in large population studies actually, specifically in women. Among brain structural predictor of treatment response, one of the few consistently reported are lower hippocampal volumes that seem to predict a worse treatment response. Therefore, the aim of our study was to investigate first the relation between neutrophil to lymphocyte ratio and treatment response, which is much less clear, and then to investigate the effect of neutrophil to lymphocyte ratio on hippocampal volume and testing a possible mediating effect. Our study was conducted on a sample of 124 patients suffering from a major depressive episode with a diagnosis of major depression, which were admitted to our psychiatric ward. The level of depression symptomatology was assessed at baseline and at discharge through Hamilton Depression Rating Score, and the 2 scores were subtracted to obtain a measure of treatment response. NLR was calculated from a routine venous blood sampling performed at admission, and all patients underwent 3 Tesla MRI scanning, and bilateral hippocampal volumes were then estimated. So what we found was first that there was a significant moderating effect of sex on the relation between NLR and treatment response, with a negative association in women and a positive one in men. NLR levels negatively affected hippocampal volumes, only left hippocampal volume on the whole sample, and both hippocampal volumes in women, with no effect in men. It has to be kept in mind, though, in line with major depression epidemiology, the male sample was much smaller, almost half. Hippocampal volumes, as expected, had a negative association with treatment response. Lower hippocampal meant worse treatment response. And finally, we identified a significant indirect effect of NLR on treatment response through left hippocampal volumes in women. We then perform a moderated mediation analysis, but we identified no moderating effect of sex in the indirect part of the model, and therefore the index of moderated mediation was not significant. On the other hand, the direct part of the model continued to exhibit a significant moderating effect of sex, again with opposite direction. Therefore, sex was found to moderate the relation between NLR and treatment response. The detrimental effect in women is in line with previous research showing an hampered antidepressant response in patients exhibiting signs of subclinical inflammation. The positive effect in men is less expected. However, to date, the only 2 studies investigating the effect of NLR on treatment response report a positive association in patients with psychotic depression. In women, NLR affected treatment response partially through its effect on left hippocampal volumes, providing a mechanistical but incomplete explanation for the relation between the two. And finally, sex moderated the direct but not the indirect part of the model, suggesting the divergent effect in males and females to be independent from the effect of NLR on hippocampal volumes.
Anybody would like to ask a question? Robin?
I didn't expect to have questions, so I've not thought of one.
Okay.
So,
what were the treatments?
These were the real-world studies. So these were patients admitted to our hospital that received preferentially as a first-line SSRIs, but then later on switched to those who have had the worst response rate switched to SNRIs and also add-on treatments for depression, such as low-dosage aripiprazole or add-on mirtazapine or add-on bupropion. We try to control for the dosage of prescribed antidepressants through imipramine equivalents, but we couldn't control for the whole complexity of the prescribed pharmacotherapies.
Thank you, Marco. Thank you very much. They've been mentioned to Eurovision Song Contest, so if you like to vote for Marco, the number is 1. And now we have Eleonora, who is playing at home because is from the University of Palermo. Eleonora, to you. Hold on, hold on.
All right. Good evening, everyone. We are going to talk about mental health in Sicilian medical students. We know that college students are at higher risk for psychological distress, and that seems to be even more true for medical students. Of course, many reasons have been investigated. For example, an interesting one is that in the last years, some studies suggested that medical students sometimes might possess a specific personality profile that make them at risk for psychological distress. Maybe those students are more competitive, reaching for perfection. Of course, that could be stressful. Lately, and besides that, the pandemic had a role in increasing mental health, mental distress, and that, of course, for the aforementioned reasons, even in medical students. So, help? Thank you. So we made a web-based cross-sectional survey, and we collect a sample of 1,866 records of Sicilian medical students. About these records, we asked our students questions about anxiety, stress and depression, also eating disorders and suicidal ideation. First, we found a score for both stress, anxiety and depression that were higher than expected compared to another study conducted in the center of Italy during the pandemic. In particular, we found severe to extremely severe score for 33% of students for stress, 53% for anxiety, and 40% for depression. More deeply, looking at DAS-21 scale, we found some specific factors that were predicting a higher risk for both stress, anxiety, and depression. For example, being female, perceiving the pandemic as a negative impact on their study, using drugs and supplements as a strategy for facing negative emotions, and also asking for tutoring and supporting for psychological distress. So maybe those students know that they need help. Looking at suicidal ideation, first, 26.4% of students declared to have had at least once in the last 6 months at the time of the survey suicidal thought. Also, adjusted score for both stress, anxiety, and depression increasingly predicted a higher risk for suicidal thought when above the sample mean. Finally, looking at the EAT26, you can see that our students also had a risk for eating disorder, both for pathological dieting, bulimia, anorexia. And as you can see here, according to the cutoff of EAT26, those students were at risk for eating disorder and especially for consulting a specialist. That's because 26.7% of students were either having a score of 20 or using laxative and vomiting or a BMI under 18. Finally, and that could be a good point of view, we asked our students if there were something that the university could do for them in order to help them with their mental health. And actually, students with stress and anxiety asked for more tutoring and psychological support, and also for the developing of an app that could help them to monitoring their mental health. We know that med students are undertreated. We think that this should be more easy to access to psychological support, but they are not. So probably in the future, our point and goal point should be to provide a preventive approach. So maybe developing an app or also helping them with psychological support. Finally, our results confirm that DAS-21 could be a good way for assessing the risk for mental health in our students. Thank you for your attention.
You did hear the Palermo Fan Club. Eleonora, while we have the poster up for Fatima, 2 quick things. We were very surprised with Professor House about the 28% using laxatives. Okay, fair enough. So it was not just... And the other thing is that, did you ask about substance misuse? Thank you very much. Sorry, Robin, you can ask Eleonora over aperitif. Fatima, to you. You've been very good at keeping on time, I have to say.
Hello.
Hello.
How does
I think
this?
you already deserve a prize for a very long journey.
I did. How does this work? What do I press?
Although no, Alessandro is.
Oh, okay.
There
No.
it is.
That's the biggest.
Perfect.
Hi, everybody. I'm Dr. Ahmed. I just finished residency in Canada. I'm about to start my big girl job soon at the Center of Addiction and Mental Health. But this was my senior research project, so I thought I would present it for you guys. So we focused on exploring the mediating and moderating effects of sexual orientation and childhood sexual abuse, and how that can impact mental health outcomes in adulthood. Where is the clicker? Yes. This? Oh, there we go. Got it. Sorry about that. So the background is that we're well aware that individuals that identify as a sexual minority have higher rates of mental illness. So those can be individuals that feel they're completely identifying as homosexual or partly identifying as such or bisexual. So there is known to be an increased risk of mood disorders, anxiety disorders, OCD, substance use disorders, as well as an increased risk of suicide, particularly increased suicidality, self-harm, and suicide attempts. They also have an increased prevalence of sexual and physical abuse, and previously studied to be 1.6 to 4 times increased risk compared to their heterosexual counterparts. So it's unclear how the childhood sexual abuse and minority status interact, and that was the purpose of this project. So we had 2 hypotheses here, a mediating effect and a moderating effect. I won't go into too much of that because I feel like other presenters have talked a little bit about that. There's some definitions there. But here the sexual minority status, I'll refer to that as SMS. And that being the independent variable, and the poor mental health outcomes being the dependent variable, and then childhood sexual abuse being the mediating variable. The second one being the moderating effect, and seeing if a sexual minority status is going to moderate the relationship between childhood sexual abuse and poor mental health outcomes. So we actually used a survey that was done, it was an adult psychiatric morbidity survey from the UK in 2007. And it was people living in like private households, anyone over the age of 16 was included, risk factors identified as identifying as a sexual minority, as well as exposure to childhood sexual abuse, which was defined as non-consensual touching or intercourse before the age of 16. There were some people in this survey that said that they didn't know or they weren't sure if that occurred, and I feel like that could definitely impact our results here. Primary outcomes identified as non-psychotic psychiatric disorders, which includes depressive disorders, GAD, social phobia, OCD, panic disorder, and agoraphobia, as well as a recent suicide attempt, which would be in the last year. We ran logistic regressions with effect decompositions to be able to break down the effect here. So the results were that out of this 7,332 people, 251 identified as SMS. The mean age wasn't exactly the same in the 2 groups, 46 in the SMS group and 51 in non-SMS. But gender-wise, equal representation, and you can see here that exposure to childhood sexual abuse in a sexual minority population is a lot higher than non-minority populations, 16.9 compared to 8.6. Same with neurotic disorders, 26% compared to 16%, and a recent suicide attempt, which is 3.2% versus 0.61%. So running the mediation models here, if you look at the direct effect of belonging to a sexual minority status, the risk of developing a non-psychotic disorder, the odds ratio is about 1.7 with significant p-values. And CSA does not really mediate a whole lot, just 15%. Same with suicide attempts. Odds ratio of direct effect of 4.49, so very significant here. And then and when you account for childhood sexual abuse, it maybe accounts for 7%. So our findings were that the mediation effects weren't very high in terms of childhood sexual abuse affecting a sexual minority status. This was to look at the moderating effects. So I don't know if you guys can see here. I wish this could be bigger for you, but this is the sexual minority status. Anyways, both of the factors increase the prevalence of psychiatric disorders and risk of suicide. We should further look into moderating effects. That's all I got. Thank you.
You're very welcome. Thank you very much. And so, a question, just one question from Argyris.
Thank you. Very important topic and very well presented. If you go back to that slide, can you explain to me, please, the causal pathway in your mediation model? Because it goes from sexual abuse to, it goes from, from being a sexual minority to childhood sexual abuse to the outcome.
Yeah.
Right. So how would that work causally? I don't like it's you know, I know you probably have them cross-sectionally the data, but this would assume that the SMS is prior. So I was just wondering about the causal implication.
So I'll try my best to answer that question. This SMS here is considered to be an independent variable, and this is its direct effect. And then CSA here is being presented as a mediating variable. And so then you break down with decompensation to see what are the direct and indirect effects to see if there is a mediating effect here. I don't know if that answers your question, but let me know if you have any other questions.
Thank you very much.
Thank you.
We can talk about causal model over the aperitif. Thank you very much for all of you that have stayed so long. So you can make your way to the aperitif, which is via Vittorio Emanuele 291 or the roof terrace of the Quattro Canti Hotel. You should all have in my email. Or you can follow me. I just have to pop to the ladies, I should say, so don't follow me there, but meet me downstairs outside the entrance of the palace, and we can go there together. Otherwise, thank you everybody for your question, the great presentation from the speakers and the poster. And don't forget to vote. So Marco is 1, Eleonora is 2, and Fatima is 3. Thank you very much.